as far as the mic goes.
Hello and welcome everyone. We're welcoming you to today's webinar. It's a high time to talk about the medical uses of cannabinoids. And today we're very lucky to have two wonderful guests, Dr. Mel Kahan and Dr. Mark Ware. And both are extremely well known in their field, probably the two lead people in Canada around the medical uses of cannabinoids. So we're very fortunate to have them both with us. They come from different viewpoints, which we'll hear throughout today's discussion. We framed it as kind of a panel discussion, if you will. And before we spend any more time on that, I want to jump to our conflicts of interest so we can get the program moving quickly. So first of all, you probably wonder, what am I using these big headphones for? Am I trying to sell a trip to Disneyland or something with these Mickey Mouse ears? But we're all in different locations today, and so we're going by Skype, and that's why I'm using the headphones. So, I'm Mike Allan. I'm a family doctor and the director of program and practice support here at the National College, and I have no commercial conflicts of interest related to this topic. I haven't taken anything from industry since 1998 when I went out to a drug dinner. But I do have a potential conflict of interest in what we call predisposition bias or academic bias, in that I have written articles on medical cannabinoids. So I get my pay from the College of Family Physicians of Canada and the University of Alberta. And I've gotten grants and speaking fees and honorarium from a variety of nonprofit sources, like the college, Toward Optimized Practice, the Alberta Medical Association, etc. Okay, and next we'll have Mark just quickly go over his conflicts of interest. Mark?
Thank you, Mike, and good afternoon, everyone. Thanks for hosting this very important discussion. My conflicts are probably as conflicted as it's possible to get. On July 1st to 2018, I joined Canopy Growth as Chief Medical Officer, so I am employed by a licensed cannabis producer. I have salary and stock options in the company. Prior to that, I was a family physician with an interest in pain management, working at McGill University and the McGill University Health Center. I had received grants from industry to conduct clinical trials. At the time of my transition to industry, I disclosed these and I stepped away from those grants. So I currently receive no additional funding from any other source. I am now exclusively on leave of absence from McGill to fulfill my role at the company.
Thank you, Mark. And Mel, over to you, who's here in Toronto, but at a different location. So, Mel?
Yeah, thank you. I have no conflicts of interest that are directly relevant to cannabis. I have been involved in the addiction field for a long time, and I'm currently conducting research and program development in that area, and currently employed by Women's College Hospital and the University of Toronto Department of Family Medicine.
Thank you very much. Okay, guys, we're going to move forward and talk, just really briefly remind everyone listening that there are objectives for this. The first is to summarize the challenges. You should be able to do that at the end of this. You should also, with your own practice experience, apply some of these discussion points and kind of bring that into your interaction with patients about their eligibility and appropriateness for medical cannabinoids. Now, just a reminder, so we've introduced ourselves a bit of housekeeping. This is this webinar is not going to be certified, but you'll be welcome to view it after in a recorded format. And during the webinar, we will be asking you questions, and you will see on the YouTube channel in the discussion or chat portion of it that there will be a Poll Everywhere link, so you can participate in kind of completing the polls, and also it'll be your mechanisms by which you can submit questions to us as we go. And we welcome questions as we're going, and I'll try and integrate those at different stages of the presentation. So what we're going to do is each of our participants will describe a little bit of their background and related to medical cannabinoids and discuss their position on medical cannabinoids. Then we'll break down into kind of 4 questions that each one will have around 4 minutes to address. And the first one is around pain management. The next one is around conditions that have less adequate evidence, and we'll have the panelists kind of discuss the challenges there and their recommended approaches. And then we'll talk about one of the things that's become of large interest to us is, of course, the opioid epidemic, and how are we managing the challenges with opioid use disorder and overdoses and deaths. And cannabis has been proposed as one of the potential interventions that can help us in managing this, and I'll have the panelists discuss that. And then last but not least, we'll actually talk about cannabis use disorder to an extent, and then we'll finish off with some poll questions. As I mentioned all the way through, we'll try and integrate some of your questions, so please feel free to forward questions right after the first Poll Everywhere question. So this is our Poll Everywhere question. We'd love you to participate. And the first statement is, I am comfortable authorizing cannabis for conditions with little or no RCT evidence, like depression, and for conditions with reasonable evidence, like neuropathic pain. The next option is, I am comfortable authorizing cannabis for conditions with reasonable evidence, like neuropathic pain only. And when I mean only there, we're talking about only those where the evidence is stronger. I'm not comfortable authorizing cannabis, but have done under rare circumstances. And the last one is, I will not authorize medical cannabis. So if you can take your time to look through the survey, see where you would kind of put yourself, that would be greatly appreciated. We know there's a bit of a lag between where this comes out. I proposed this question and sought feedback from Mark and Mel. From my experience when speaking on medical cannabinoids, we get a lot of, I get quite polarized view from everything from kind of an almost certainty that we can never prescribe medical cannabinoids all the way to doing so with very little evidence, or evidence mostly around anecdotal reports and case reports. So, looks like we're having a tiny bit of trouble with the poll everywhere. So, okay, so we're going to press through on the. Unfortunately, we didn't get to that, but I want you. We'll be coming back to that question in another format. This area of the poll everywhere now is available for you to begin to put your questions, and I will sift through those and feed them back to the participants. Okay, so before we get into the discussion points, what I'd like us to do is try and address just a general approach to your thoughts around medical cannabinoids for about 4 to 5 minutes, and we'll ask each of the panelists to do that. So, Mark, why don't you start for 4 to 5 minutes? Just give your background in the area of medical cannabinoids and where you think their utility is, and where their strengths are and where their weaknesses are.
Sure, Mike. Thank you. So perhaps by way of background, I worked at the McGill University Health Center Pain Clinic since 1999, and gradually worked my way through the academic ladder, studying medical cannabis as a treatment option for patients with chronic pain, mostly non-cancer pain. And this was initiated because, as many family physicians and other specialists will recognize, patients are coming in asking about it. And I realized 20 years ago that there was very limited evidence on which to base decisions. So I began applying for funding and developing research programs to look both at the safety and efficacy of cannabis, less in the pharmaceutical form and more in the dried cannabis, medical cannabis, which I think is important to start to differentiate. The purpose of this discussion is about the medical use of cannabinoids, which of course implies that we're working on the active ingredients or the chemicals in cannabis which are most believed to have some therapeutic activity. In the time that I was studying this work, the available funding was for dried cannabis. Early 2000s, the studies were insisted to be studied both cannabis, as that was a major mechanism by which people were using cannabis. So our first trial, it's a program. I don't have it. Agencies and
I don't know where it is.
Pain. So the research line was very clearly focused on particular modes of administration and on particular patient populations. Of course, as time went on, it became clear that patients were using cannabis for a lot of other pain conditions, for arthritic conditions, for generalized pain syndromes like fibromyalgia. And we began exploring as much as we could use of different cannabinoid compounds like nabilone and other compounds to see whether there was a chance that these compounds could add some value to the therapeutic strategy of pain management. I think it's important to point out that at no time do I think or suggest that cannabis or cannabinoids are a standalone cure-all for chronic pain. The reality is that most physicians who see patients with chronic pain will realize that the right approach is a combination of pharmacotherapy, physical therapy or physiotherapy, and a psychotherapy approach. It's a complex disorder. However,
Mark, you're cracking up there a bit. So I'm just going to see if the team has is it a Skype problem or is it? Okay. Mark, I'm going to give you a sec there, and I'm just going to go to Mel. I'm sorry about that, but we lost a bit of what you were saying, and I don't want to miss that. So I'm going to give a chance for Skype to kind of catch up. Mel, do you want to wage in now to your kind of background and your history and where you think the strengths and weaknesses are of cannabis and as a medical treatment?
Sure. I've been an addiction doctor for many years, for well over 30 years. And I was involved in the 2014 College of Family Physicians preliminary guidance document on the prescribing of dried cannabis. I come to this from a very different view than Dr. Ware. I was right at the beginning of the opiate epidemic, and I think to a large extent the opiate epidemic was what you might call a pharma epidemic. That is to say, a pharmaceutical company was aggressively marketing their product, OxyContin, that profoundly changed physician prescribing of opiates, and it resulted in great harm. And I'm seeing some parallels now with the aggressive marketing of cannabis for conditions for which it's not indicated and it's not safe, and legalization is going to compound that. Now, clearly, cannabis does not cause, thousands of opiate overdose deaths or anything, but let's be clear, it will really cause serious harm to many people if it's used inappropriately and in high doses. So my message to physicians is, first of all, to realize, as Mark said, that dried cannabis is completely different than the pharmaceutical cannabinoids in terms of its safety profile and also its effectiveness profile. And the companies are mainly marketing dried cannabis products. I want to emphasize the difference. First of all, people continue to smoke cannabis. That's their primary way of taking it. That is a very unsafe delivery system. It reaches the brain within seconds, causing cognitive impairment potentially, and causing a euphoric effect. Smoke creates many dangerous chemicals and products, including atherogens and carcinogens. And nabilone and Sativex, or nabiximols, the two main pharmaceutical cannabinoids, are legal and they're pure, and they have a much smoother distribution, and they're much less likely to cause harm. In fact, there's also much better evidence of benefit for chronic pain. For example, a systematic review found that there were 10 RCTs on nabiximols for chronic neuropathic pain. There were 3 RCTs on oral cannabinoids such as nabilone, and only 2 RCTs on dried cannabis. So I want to emphasize that always the pharmaceutical cannabinoids should be first line and should be given a therapeutic trial.
Okay. Oh.
Sorry.
Are we losing Mel too?
Can you hear me?
Just now we did, Mel. So we lost you for about a half a minute there.
Okay. So I was just trying to say that cannabis is very different in terms of its safety and effectiveness than pharmaceutical cannabinoids, and one should always go with nabilone and Sativex first. Second point is to be very careful about prescribing products with high THC. The companies are producing and marketing products that contain extraordinarily high amounts of THC, 20% or more. These are unsafe. There's no evidence of benefit for them. And the harms of cannabis are mainly related to THC, and the more potent, the greater the harms. And these harms include motor vehicle accidents, psychosis, addiction, anxiety, and so on. So if you are going to prescribe cannabis, use no more than 9% THC and no more than the equivalent, or no less than the equivalent amount of cannabidiol. The other last point I want to make is to rely for your prescribing on evidence-based guidelines that are produced by independent medical groups, such as the one that Dr. Allan produced, the simplified guideline to cannabis use in chronic pain, or the 2014 guideline from the College of Family Physicians. And this is important because the companies that are marketing cannabis and many of the medical clinics that are prescribing cannabis are not reliant and don't have to comply with any direction from Health Canada. Unlike other pharmaceutical companies that have to have a product monograph that lays out the evidence-based indications and contraindications and dosing and so on, these companies can say pretty well anything they want, and many of their claims are in fact not supported by evidence. The claims generally are based on anecdotes and studies that are self-reported. And the problem with studies using self-report for a psychoactive drug like cannabis is that any drug that potentially causes pleasant euphoric, such as alcohol or cocaine or opiates, will relieve pain, will relieve anxiety, will improve mood, however, in the long run, they make things much worse. So if someone says that cannabis pain self-work through function, that's not accurate. And in fact, for cannabis, for many conditions, including anxiety, the evidence is quite clear that cannabis makes things worse, especially with high THC doses. So these are the kind of main points I want to make in the introduction.
Okay, thank you, Mel. That was great. Mark, I'm going to go back to you now. I'm hoping we're going to have a good run, and I don't want to interrupt you or put a time limit on because you got interrupted last time. So please, I'll only cut in if you're having troubles with with the audio again. Unfortunately, that was very unfortunate. Would you mind giving it another go?
No problem, but let me just check that you can hear me okay this time around. Is this working okay?
Yes, it is. Yep.
Okay, fantastic. So I agree with Mel in that the evidence base is challenging. Most physicians are working in context of chronic pain with patients who are struggling to manage their pain in spite of the best available evidence, and they're coming in with side effects or with poor control of pain, even using the drugs in which we do have reasonably good evidence. So this is the context that physicians are facing. And I'm as concerned as Dr. Kahan is about the risks. But I think in any clinical decision, you're trying to balance minimizing harm with maximizing benefit. And there are ways that physicians can use cannabinoids in a safe way for adequate screening, using lower doses, balancing CBD. But it's important to point out that for a lot of what Dr. Kahan is presenting, including using prescription cannabinoids as a first-line agent, when considering this, it's also based on fairly thin evidence. Nabilone, which is being used quite extensively by physicians in Canada, has a very limited evidence base for use in pain conditions. I did one study with fibromyalgia patients. I'm not aware of very many formal clinical trials where nabilone has been studied for chronic pain, and yet we're more comfortable using it. Now, I should point out, nabilone is a very potent CB1 agonist. It's a very strong cannabinoid, and in theory has the same risks as cognitive impairment, driving-related accidents, long-term dependence, and so on. So far, the data that we've done, and I've done long-term safety studies with nabilone to suggest that it's not abused, it doesn't seem to have this addiction potential. There's no reason why we shouldn't be doing the same kind of work with cannabinoids. And in fact, as much as Dr. Kahan points out the use of cannabis as a smoke drug, we're seeing increasingly patients using cannabis in oral form, in oils or in soft gels, which are now becoming available. So mitigating the risks of smoking is something that clinicians can inform patients about. There are vaporizers, there are other methods of delivery which can minimize risk if they are looking to use cannabis or cannabinoids as a therapeutic option. And it should always be done in full collaboration with the patient and in the context of a comprehensive pain management strategy.
Great. Okay, thank you, guys. I'm going to, one of the questions that's been posed is actually highly relevant to a question that we have coming up. So I'm going to switch to our questions right now, and then I'll get you each. And Mark, you started and finished first and last, so I'm going to have Mel start this time. So the question that we'd like you to specifically address, Mel, is most family most family physicians have patients with conditions of pain that are not adequately managed with treatments presently available. So I want you to address that piece, which is, and focus here on those with neuropathic pain, the ones that and I'm saying neuropathic because that's where we have relatively good evidence. But I want you to also then go into a little bit of the discussion around other pain conditions where the evidence is not as strong. So things like back pain and headache. And so Mel, we'll start with you and then go to Mark.
Well, I think there are two situations that doctors commonly confront. One is the patient who is already using cannabis for a pain condition. And there, I think the questions that you need to address are, is it helping him or her? And are there any harms that are resulting? So if you have a patient who is using a small dose of cannabis with CBD, a small dose of CBD equal to or more than THC, and they have no risk factors for cannabis problems, and they say that it's helping to improve their daily function and their activity and their mood, of course, you would support that or endorse it or even prescribe it if necessary. However, if you have a patient, on the other hand, who says that they have chronic pain, neuropathic or otherwise, and they're at high risk for harms, they're younger, they have concurrent anxiety disorders, they have a past history of substance use, they're smoking very high amounts, 2 grams of 20% THC or more, they're having social dysfunction, they're not involved in work, they're socially isolated. There's a very good chance that that cannabis is in fact harming them severely, and the physician needs to address that and work with it. So I think it all depends on the patient presentation. You have to individualize your therapy and your approach. Of course, cannabis does not harm everyone or even most people, but you know, it is a significant harm. And the second scenario I just want to mention is when a patient isn't on cannabis, but they have poorly controlled neuropathic pain despite a good trial of first-line medications. And there one might consider the pharmaceutical cannabinoids, but as Mark said, the evidence for safety and effectiveness is, while it may be limited, is still far greater than for dried cannabis. So I would use sativexor-nabilone first in an adequate trial. And then if you are going to try dried cannabis, first of all, I'd be careful about patient selection. I would avoid using it in high-risk patients, that is those with concurrent anxiety and substance use disorders and so on. And I would use a small dose with small amounts of CBD and THC.
Great. Thanks, Mel. Mark, do you want me to read the question again, or are you okay to jump in?
No, I'm okay to jump in. I think it's something which most physicians who are participating in this panel will recognize. They will see these kinds of patients, as Dr. Kahan pointed out, the one already using, the one who's curious. And I think in today's world, where we have legal cannabis now recreationally available since October of last year, I suspect clinicians will be seeing more and more patients coming in asking if they should think about cannabis for a wide range of conditions, including pain management, as well as many others, which we may discuss later. So the approach is a good one. Proper patient screening, informing the patient of what we know about the potential risks and the potential benefits, and also what we don't know, that there are gaps in our knowledge. But I think the other key piece in both cases is proper monitoring of the patient and follow-up, ensuring that if they are going to continue using cannabis in whatever form as a therapy, that you have clearly defined treatment goals and that the patient works towards achieving those. And if the treatment goals aren't met in a reasonable space of time, that the therapy be discontinued and you move to the next line of treatment. So I think good medicine applies here as well. And there are many circumstances where physicians are using medications off-label or for which there is limited evidence, but they can still do it in the context of proper patient care and proper patient follow-up. And so that's the piece that I would add to this, is really adequate patient follow-up. And unfortunately, we don't have good guidelines, and clinicians aren't well educated as to how to initiate and follow patients carefully if they're considering using cannabinoids as a therapy.
Excellent. Yeah, so I hear from both of you that it is much like it would be wonderful if this was a concrete thing that we could say one way or the other. Everyone should be offered it first line or something like that, but it's just not that way. It's much different than that. It is a potentially dependent substance and all sorts of things, and it requires a much more nuanced approach based on the individual patient in front of you. So I appreciate that. I think as clinicians, that's our job. We have to accept that many of the things that lie in front of us are not simple black and white answers. And so I appreciate that. There is a question that I think could be relevant to this, and I'll start with Mark addressing this because I think he might have a little more given his research background. But this is a question around you know, the newer products that are coming available, like oils and that kind of thing, and asking, what do we really know about the differences between oils and whether they're smoked, whether they're consumed as an eaten? Does that change the effectiveness of these, or how quickly they work, or their adverse event profile? How does that work if whether it's smoked or whether it's consumed orally or something like that? Where are we with that, Mark? Do you know?
So as Dr. Kahan pointed out, when you smoke cannabis, you get a very rapid plasma level. It's a quick onset. It doesn't last very long, 2 to 3 hours. And of course, in large doses, the risks of having central effects, cognitive effects, and so on become much higher when you're taking a large dose. In all our trials, and as best as we can, we've always advised that patients use the lowest possible dose to achieve the therapeutic benefit and minimize the likelihood of any impairing effects. And long-term studies have shown that patients, generally speaking, with chronic intractable pain conditions are able to find a dose which can lead to improved function, improved pain control, and minimize the likelihood of central side effects. So I think dose selection is important even in inhaled cannabis. Of course, for that short-acting effect, the vaporizer, there are 2 medically approved vaporizers in Canada, so physicians can counsel patients who are using it in an inhaled route to use a much safer method. We know it's clear now that vaporization yields much less toxins, much fewer polyaromatic hydrocarbons and the kinds of toxins in smoke, so that's a safer approach. The oral route, as you point out, the oils and the capsules, look much more like the kind of pharmaceutical cannabinoids that were mentioned earlier. Nabilone and nabiximols are taken orally, they're absorbed through the stomach. There's a much slower onset, 1, 2, sometimes even 3 hours before the effect starts to be noticed. And of course, it lasts a lot longer. It's a much longer acting approach. It's been quite surprising, in fact, to see how patients with chronic pain, which is of course a long-term chronic condition, respond reasonably well to these kinds of longer acting, slower onset medications. It's a chronic stable condition, and a slow level of plasma levels of cannabinoids, in fact, is a good fit. So I think there's good reason to be considering these oils as an option to inhale cannabinoids. And for most patients, they simply aren't aware that cannabis is available in this form. So very important that clinicians know what the different administration techniques and routes are that are available to them legally.
Thank you. Mel, anything to add to this? And it is kind of a wave right now. We're seeing a lot more enthusiasm for all the alternative delivery systems and the alternative products, particularly the oils and edibles. So Mel, any thoughts about them as far as an intervention for, and you could also weigh in on their, like, are they potentially less safe, that kind of thing?
Well, I think it's true, as Mark said, that they have a slower onset of action, so that, you know, for a given dose, they're less likely to cause intoxication, and they may even last longer in terms of pain control. But there have certainly been numerous reports of people using edibles with candies and so on containing very large amounts of cannabis that get absorbed and cause a very toxic reaction, including psychosis. So I think that the edibles need to have the same kind of pharmacokinetic and pharmacodynamic testing as any pharmaceutical product before you can say that they're actually safe.
Thank you for that. So our next one, and I think we'll go to Mark first for this one, is family physicians also encounter patients requesting cannabinoids for conditions where the evidence base is poor or absent. And examples of that Mark knows the anxiety evidence is weak, at least the RCT evidence. It's really based on one RCT, and the depression evidence is absent. So how do we manage that? And then I'm going to put on top of that, if you will, the idea that some of our patients will report that they're already, and Mel brought this up earlier, that they're already users, and they'll say, when I use this, my anxiety is far better. And we know that that's, how do we differentiate that that's actually helping the patient with anxiety versus what is likely, as Mel pointed out, the high that they receive from the product, and therefore that's what's relieving their anxiety, and it's really only working short term. So first of all, two-part question is how do we manage the patients requesting when there's poor evidence base, and then what about when they actually tell us they've actually know about it, they've used the product, and say it is working?
Yeah, this is a really tough question, because and perhaps I'll start just by reminding us that just because there's no evidence doesn't mean that it couldn't be potentially effective. It just means we don't have evidence one way or the other. We do know that certainly cannabinoids can worsen anxiety in some patients. We do know, I just published with a group of colleagues a systematic review of cannabis use in young people being associated with worsening outcomes in terms of depression later in life. So we know that in certain patient populations, risk factors are important. I certainly don't think that in young people, adolescents, that using cannabis as a treatment for anxiety and depression is something that can be condoned. I think we're talking here about the use of cannabis in adult patients with intractable anxiety disorders as an option to, or as an adjunct to, other approaches that they might be considering. Of course, we know that there are harms associated with existing anxiety medications, benzodiazepines in particular. So the question becomes a relative risk. Are cannabinoids more harmful in terms of potential liability than existing benzos? I don't think we really have to.
Okay, Mark, we're losing you again. Sorry, losing you a bit there. Just try one more time and let's see if we can hear you this time.
Okay, I'll try and remember what I said.
Sorry.
No, it's okay. I think but my counsel here is that we aren't talking about using cannabinoids in young people in adolescent treatment. We know that there are harms with using cannabis early in life, and that those are clear. The issue is in older patients with anxiety, and comparing cannabis and its risks with other existing medications like benzodiazepines. So it's always a question of relative risk with existing therapies. And of course, for some patients, anxiety is debilitating, very troublesome, and in the same way that chronic pain doesn't all respond to existing therapies, there may be patients who wish to try using a cannabis preparation as a self-medication for anxiety, and that can be brought into the clinical context with proper education and follow-up.
Okay, thank you, Mark. Mel, your thoughts on this, and would you like me to read the statement again that you can, or are you ready to jump in, do you think?
No, I'm ready.
Okay.
I'd like to just focus on post-traumatic stress disorder, because that's one anxiety disorder that there's been a lot of talk about, and how cannabis could cure it. I would say a few things. Mark is right that THC in particular has been associated with worsening anxiety, and can in fact cause de novo acute anxiety in patients who are not, who don't have existing anxiety. I wouldn't totally agree with Mark that cannabis is equivalent to other medications in terms of its known safety. In fact, the studies on PTSD and cannabis have by and large been pretty negative, and have found strong associations with poor outcomes. Studies based on self-report, yes, there will be some patients who report that it helps their mood and so on, but studies with more objective, comprehensive measures, cohort studies have found that heavy cannabis use in particular is associated with harm. For example, a study of veterans in the United States who are waiting to go into an inpatient residential treatment program, the ones that started cannabis at any time before or after their residential treatment program had worse outcomes in terms of including violence, compared to those who didn't use cannabis or stopped it. So I would say that the bulk of the evidence is extreme caution with cannabis, particularly THC. Now, CBD may have an opposite effect. It may have an anxiolytic effect. And pharmaceutical cannabinoids, I know Navalon has had some benefit in post-traumatic stress disorder. That's another example altogether. But again, to emphasize that any drug with a pleasant euphoric effect is going to be perceived as relieving anxiety, including alcohol. Alcohol is a remarkably effective anxiolytic in the short term, but the problem is that heavy use can lead to serious problems.
Thank you, Mel. One of the things that you mentioned, and actually Mark has mentioned too, the CBD versus THC, and of course, as you know, that's kind of one of the movements that's going on right now. Maybe if we were more nuanced in how much THC versus CBD we're using, and particularly if we focused more on the CBD, we'd be able to treat other conditions without some of the adverse events, or at least not as many of the adverse events. Mel, you mentioned a little bit about it. Would you care to kind of just wade in a tiny bit more on the CBD versus THC? Your thoughts there.
Well, there's some evidence that CBD does have a reduction in anxiety, a calming effect. Most importantly, it's not associated with the harms that THC has, including euphoria, addiction, and cognitive impairment. Furthermore, preparations that have equal amounts of THC and CBD, the CBD seems to counteract to some extent the effects of THC. So I think that there is some promise in CBD. Unfortunately, the cannabis companies are producing, like I say, these extraordinarily high and potent THC products for which I think are harmful, and there's no evidence for medical benefit.
Thanks. Mark, your thoughts about this CBD and THC distribution components as far as for medicinal purposes?
So I think it's, well, maybe just to pick up on Mel's last point, cannabis companies are, of course, also producing CBD in capsules and oils, and for many clinicians, there are guidelines or guidance preparation documents being put together that suggest that CBD only or predominant CBD preparations should be tried if you're going to consider cannabis therapy as a first line. So the availability of CBD predominant oils and capsules and even flower or herbs are now there. So, and this is important because it's a relatively recent piece of the story. Up until 4 years ago, there were no CBD preparations available. When I was doing trials and studying cannabis in 2000 to 2015, there was zero access to cannabis with any CBD in it. So this is a very new and obviously very exciting for the reasons that Mel has pointed out. But I would also caution that CBD is metabolized by liver enzymes, and in high doses, those can interact with other medications that patients are taking. So I don't think we should be walking away thinking that CBD is entirely without its own potential harms. And we know from pediatric epilepsy studies where CBD has been used in very high doses for children with intractable seizure disorders, that there's a well-described interaction with clobazam, a commonly prescribed anticonvulsant. So I think we have to always be careful. We don't jump on the CBD bandwagon assuming it's completely safe. It may turn around and have its own risks. So I certainly wouldn't advocate for a wholehearted absorption of CBD as the safe cannabinoid. The evidence around combining the two is very compelling, and it would make a great story if it was in fact that powerful. I've done studies comparing side effects of THC-only preparations with THC and CBD preparations, and in fact the harms or the adverse events, both quantitatively and qualitatively, are quite similar, even with the presence of an equal amount of CBD. So again, let's just be careful that just assuming that there's CBD there doesn't mitigate completely the likelihood of having central effects from THC alone. It may be that the levels of CBD required to actually have those effects are much higher than are available in standard one-to-one therapies. So I think there's a lot more work to do here, but what is encouraging is that we have CBD preparations available, and there's a commitment to doing major studies on CBD in both anxiety and pain disorders.
Thank you. Thanks for that. Mel, we're going to go back to you with our next discussion point, and that is, well, some feel that the enthusiasm for cannabis mirrors errors around opioid prescribing from 20 years ago, and you mentioned this in your opening statement. There are also a lot of people who feel that cannabis can be very helpful in managing patients with opioid use disorder, either to decrease those people on high doses, to decrease their doses, or potentially even help in having them stop using opioids entirely. Now, as I said, there's kind of these two camps, very strong opinion, and I'm wondering, how do you reconcile these two approaches? One, that it could be this panacea that's going to fix from our opioid epidemic and opioid use disorder, or at least help treat it, and all the way to the idea that maybe it's actually just we're making the mistakes of the past again. How do you kind of reconcile this?
Well, the idea or the notion that cannabis helps with opiate use disorder was based on a couple of studies, what we call ecological studies, where in states in the United States, they found that overdose rates from opiates were reduced in states that had legalized cannabis. This is a very weak form of evidence because they're not linking a patient's actual use of cannabis, an individual's use of cannabis, with their overdose risk. They're talking about a statewide level. And in fact, subsequent analysis has shown that there is no association when you take into account past time frames and overdose rates. Observational studies have clearly shown that patients who use cannabis are more, in fact, likely to also be prescription opiate misusers, to use opiates in higher doses. And that's not surprising. We know that there's a strong association between drug use in general. That is, someone who drinks alcohol heavily is more likely to use cocaine, is more likely to use opiates, and is more likely to use cannabis. There is, I think, clinically, some pretty strong evidence that someone who's a heavy cannabis smoker is, in fact, less likely to recover because of the effects of cannabis on motivation, making them more depressed, making them more anxious, and you're dealing with two potential addictions rather than one. Finally, I have to say there are some very strong treatments available for opiate use disorder, that is methadone, buprenorphine, and other treatments. And I think, and these have a very strong pharmacological rationale, which I don't see with cannabis. And I'm really concerned if people think that by smoking a lot of cannabis, they can somehow cure their opiate use disorder. I don't think there's any evidence whatsoever for that. Now, the second point, which is quite a different one, is will cannabis be able to help people use a lower dose of opiates? And to the extent that cannabis is an effective analgesic for a particular patient, then yes, they may be able to lower their opiate use for that. That's not related, however, to opiate use disorder. The issue for opiate use disorder is not pain so much. It's the psychoactive effects of the opiate and withdrawal and so on and so forth. So yes, if you have a patient with intractable pain who's on a high dose of opiates and they're a good candidate for cannabis therapy, then give a careful trial of it to see if they will, in fact, have a lower opiate dose.
Thank you, Mel. Mark, over to you. Do you want me to read the question again, or are you happy, or the statement again, or are you happy to jump in?
No, happy to jump in, and perhaps just a couple of points just to pick up on what Mel was saying. I do disagree. I think that the pharmacological rationale for cannabinoids to have opioid-sparing effects is actually incredibly strong. There are very good animal studies showing that these two compounds, cannabinoid and opioid, both synthetic and THC, are very synergistic, and that small doses of both have been shown in animal models to be extremely effective at securing the same level of behavioral response to painful stimuli than therapeutic doses of each together. So this synergism comes from a very strong pharmacological rationale. And I think the lack of evidence in clinical trials is one thing. I think there's clear that we need the critical need is to do trials with patients on high-dose opioids or with opioid use disorder where cannabinoids are actually tested with proper outcomes. And I think that's absolutely critical. And there's a big commitment now in the industry to start looking at those kinds of outcomes in FDA-sized and approved clinical trials. The issue with the ecological evidence, though, I think is always a little bit challenging. It's interesting to me that some people like to use association studies, as Dr. Kahan did with PTSD and veterans, cannabis use being associated with mental health problems and outcome. That's an association study, but that seems to be okay. But an association study that shows that states that have approved medical cannabis laws have 25% reductions in opioid mortality, suddenly this is now an association study with no validity. So we can't really pick and choose associations where we like them and where we don't. It's unquestionable that this use of cannabis is by patients and at this association level is associated with changes in opioid prescribing, antidepressant prescribing, reductions in sleep meds, anxiolytics. There are huge changes in prescribing patterns in states where medical cannabis is available. Now, I'm not going to argue that it's causative, but I think when we're facing an opioid crisis where thousands of people are dying and the best available treatments aren't getting to these patients, as good as buprenorphine and methadone might be, these people are still dying every day. And we are morally bound to look at something that could potentially have an impact. And I think cannabinoids is a strong enough basic science and ecological rationale for us to be taking this very seriously indeed. And to say that there's really no evidence and not move forward on that is not a tenable position. I think we have to take this very seriously indeed.
Okay. I'd like to wage in here with one of the points that was raised, and I think it's highly relevant to what we're talking about. This came as a question very early on, and it asked if cannabinoids contribute to a reduction in tolerance to opioids, and if there's a risk with that. So a patient's on opioids, they start to use cannabinoids, and then their tolerance for opioids goes down, and therefore they're much more at risk for the adverse events associated with and the serious hazards of dying with the use of opioids because of that change in tolerance. Mel, I'll start with you, and any thoughts on that point?
Sure. First of all, I'd like to respond to Mark. An ecological study is not at all the same as an observational study. In an observational study, you're looking at an association between an individual's use of cannabis and a certain outcome, such as opiate overdose. And what I'm suggesting, in fact, what I'm saying is that studies have shown that people who are using cannabis are more likely to also be misusing prescription opiates. So there's an association between cannabis use and opiate use disorder and opiate use in general. An ecological study, there is absolutely no association between the individual who has died of a fentanyl overdose, and we don't even know whether they'd be using cannabis necessarily. So that's why observational studies are much, much stronger than ecological studies. The second point that I would say is that you absolutely cannot say that cannabis is a potential treatment for opiate use disorder or opiate crisis. There's simply no clinical data. There is no pharmacological rationale for it. What you talked about is cannabis's potential to reduce opiates for pain. That has nothing to do with opiate use disorder. What makes opiates addicting is their psychoactive effect and their pleasant euphoric effect and their relief of withdrawal. And that's why methadone and buprenorphine work. Adding another potentially addicting drug on top of that, such as cannabis, is not going to help, and in fact it's going to make things worse. And until you have a really good, well-controlled clinical trial to show that, which I don't think is ever going to be done, then I think it's not right to actually recommend that as a treatment for an opiate crisis.
Mel, could you address the question from the audience, the idea that cannabis somehow changes our tolerance to opioids or of our patients?
Honestly, I can't. Mark may be able to better answer that. I didn't know that cannabis changes tolerance to opiates. So.
Okay, I was unaware of that too. Mark, do you have any feedback for that piece?
No, I've heard the risk, and it's a theoretical risk, and that being that if these two drugs are synergistic, and we know they are, if you have somebody on a high dose of an opioid and you add a cannabinoid to that mix, does that make the opioid more potent and thereby enhance the likelihood of risk of that opioid? So far in clinical practice and from the observational work that's been done, there doesn't appear to be evidence of that. But what we need are guidelines to suggest that if a patient on high-dose opioids is administered a cannabinoid as an adjunctive therapy, what are the best ways to reduce the opioid? Is it a 10% reduction every week? Is it half the dose? Do you wait until you have a therapeutic response with the cannabinoid before you reduce the opioid? These are questions when doing other opioid rotation clinical work. So same kinds of questions apply, but I don't see that because the two receptor pathways are so different, I don't see evidence emerging yet that adding cannabinoids to opioids increases the tolerance or the likelihood of risk of the opioid by itself.
Thank you. So, guys, just in the interest of time, we're going to jump to the last one, and it's going to come back to Mark first. So, and this is our last of our discussion points. So there are patients who have cannabis use disorder or similar, and they present to their family physician seeking authorization of their medical cannabis. Now, certainly the legalization might change this somewhat, but we still have I think we'll still have patients who are clearly in that kind of camp, or we're suspicious or concerned that they are, and they're asking for authorization for medical cannabinoids. So how do you reconcile this issue, as much as we have patients who aren't, who are suffering from pain, and we're kind of at our wits' end as far as what to give them. We've got the other side of the coin, which is these patients who come in and often I've seen it in my practice where they haven't tried any other agent and they just want to jump to cannabinoids, and I'm concerned about their issue of dependence and cannabis use disorder. So Mark, if you could start with that one, and then we'll switch over to Mel.
Thanks, Mike. I'm going to defer to Mel's expertise in defining and reminding us what those elements of cannabis use disorder are. Clearly, it's a recognized syndrome, and it's diagnosed in the DSM-5, and the criteria are well defined. I think that the recreational legalization of cannabis actually increases the need for physicians to be vigilant about cannabis use and potential problems. When prior to legalization, patients were coming asking for access because it was the only legal way to get it, then it became a question that physicians and Mel's guidelines recommended that using the cannabis use disorder guidelines should be used as screening tools, and that's fair. I think in the absence of medical use, where people may be using cannabis recreationally, they could still qualify for cannabis use disorder, and so physicians need to know what these are and how to screen for them. I think where it gets challenging is separating out what is safe and responsible cannabis use, somebody who is not at risk, who uses cannabis in a sensible way as part of their recreational lifestyle choice instead of alcohol, and we're beginning to see people using cannabis now instead of other drugs like alcohol and substituting. So having these conversations with patients is very important, and recognizing that there will be a large number of people for whom cannabis use isn't a major problem for them. They are able to counsel their use, they're able to titrate it, they're able to continue being professionally active and have healthy and happy lives. So understanding when it becomes problematic is something that I think is a really important thing for family physicians across Canada to be able to recognize now. And so I would ask Mel to help us understand how and when to recognize that in our practices so that we can counsel those patients to get the appropriate help, but not to lump everybody who uses cannabis as a recreational therapy or as a pain option as being somebody with a diagnosis of cannabis use disorder.
Thanks, Mark. Mel, over to you.
So cannabis use disorder is characterized, like other addictions, by generally daily heavy use. However, that's defined 2 or 3 grams or more, particularly of high-dose THC products or high-potency THC products. As the patient is spending a lot of time using, with not much else. They're not productive. They're spending hours and hours in their house or room or whatever, smoking and using. They have social dysfunction. That is, they're isolated. They may not be productive. They're not involved with their family. They tend to have a poor mood, anxiety and depression. And they have difficulty stopping because the majority of very heavy users will, in fact, have withdrawal symptoms. So they will try stopping and they can't for longer than a day or two. The risk factors for cannabis use disorder are a pre-existing anxiety or mood disorder, and that's when the patient finds that cannabis helps their mood. A pre-existing substance use disorder, either past or current, and youth, younger age, and possibly male. So young men who have had a problem with alcohol or drugs in the past, who have an anxiety or mood disorder or PTSD, are more likely to develop cannabis use problem. The treatments, pharmacologically, the treatments are cannabis replacement with nabilone, for example, or acetylcysteine or some other agent. But the mainstay of treatment is individual and group therapy. Part of the problem is it's hard to convince patients sometimes of the need for treatment, especially if they feel that the cannabis is essential for their mood or anxiety. But I agree with Mark that all physicians need to be aware of cannabis use disorder, to recognize it, and to make appropriate referrals and interventions, because one can anticipate that the prevalence of cannabis use disorder will be going up with legalization.
Okay, thank you very much. We're going to move back to the slides now, and we're just going to, because we're running out of time, but we did want to give an opportunity for people participating in the webinar to, again, have a vote. And the questions were, I'll just review them again. I'm comfortable authorizing cannabis for conditions with little or no RCT evidence like depression, and for conditions with reasonable evidence like neuropathic pain. I'm comfortable authorizing, the second one is I'm comfortable authorizing cannabis for conditions with reasonable evidence like neuropathic pain only. And then the third choice is I'm not comfortable authorizing cannabis, but will do on some rare occasions. And the last one is I will not authorize medical cannabinoids or cannabis. And as you point out, when we say cannabinoids, we're talking about nabilone, nabiximols or Sativex, if you like, and as you guys pointed out, the research for nabilone in pain is not very strong. It's just there's just not a lot of it. But for nabiximols, the research is actually quite robust in the pain area. But anyhow, we're seeing here that a lot of people are kind of positioning themselves in the I am not comfortable authorizing cannabis, but will do so on rare circumstances. And I would say it's interesting that my experience is that a fair number of my colleagues sit in that kind of camp where, and I think it also came out in some of the questions and the very statements given by both our panelists, and that is that this is a challenging thing. And we got into medicine despite all of the jokes about us getting into it for money and all the other reasons and fame. We did get into it to help people, and we're really, when you're confronted with someone who you know is suffering and you want to make things available for them, if you do address the potential risks and harms that we've discussed earlier, the costs of medical cannabinoids, and you've tried some of the pharmaceutical-derived cannabinoids, all that kind of thing, I don't think that any of us would dismiss the use entirely, but it is a very nuanced area of medicine that requires some thought. And I think both of our panelists did an excellent job today. They absolutely have different viewpoints, that's clear, but I actually saw as much or more common ground than I saw a really polarized view. So I really appreciate you both for participating in today's webinar, and I know I changed it from a debate to this kind of discussion, and I hope that was okay for both of you, but I know that our participants really did appreciate it. Thank you very much.
Thank you, Mike.
Thank you, Mike.
Thank you, Mark.